dialing in. Really looking forward to today's seminar. So my name's Mark Shackleton. I'm a co-director of the Monash Partners Comprehensive Cancer Consortium, and this is the next installation in our cancer seminar series, our precision cancer seminar series that is now being run coordinately with the Monash Biomedical Discovery Institute based in Clayton. So I'd actually first like to open today's seminar by acknowledging the traditional owners of the lands from which we're joining together today, and respectfully acknowledge their elders past, present and emerging, as well as any members of the Aboriginal and Torres Strait Islander community that are gathered amongst us here this afternoon. So this this seminar series represents a community of researchers and health professionals and academics that work across our state and sometimes nationally and internationally in the fields of oncology and malignant hematology, and they've been a great vehicle in the last few years for helping us to share information about research activities, particularly across the MPCCC partnership, but obviously beyond that as well. Today's seminar we're really excited about, very close to my heart. It's around the topic of molecular pathology, and with a particular consideration for how developments in this field that have been incredibly rapid have strengthened the diagnostic skills of our pathologists. So along that line, we're incredibly fortunate to have today have as our guest speaker Professor Beena Kumar. Professor Kumar is a pathologist with over 20 years of clinical teaching, research and leadership experience in the delivery of pathology services within the public health system, particularly at Monash Health. She's really one of the doyens of this field. There aren't enough like her in pathology, and we're certainly very grateful for her career commitment to the public pathology system. Hard to underestimate the role that those leaders play across the delivery of public health, particularly in this era of dominant privatisation of pathology services. So she's been part of Monash Health since 2006. Her current role is as the Program Director of Pathology at Monash Health, and that involves, of course, clinical governance and operational responsibilities of a very large and dynamic department of over 500 employees that are responsible for making dominantly responsible for making the malignant diagnoses upon which all of our treatment decisions are fundamentally based on. Incredibly important central role in delivering cancer care across our precinct. Today's seminar is going to outline some real life cases on how molecular assays are increasingly supporting pathologists to improve the accuracy of cancer diagnoses, and also how those diagnoses link into potentially available therapies. So she'll also touch on some of the latest developments in her department, which I'm particularly interested to hear about. So thanks so much, Beena. Welcome to our seminar series. It's wonderful to have you as part of the MPCCC team. We really look forward to your seminar today.
Thanks, Mark. And in the interest of time, I'll get going. So I hope my slides move. Oh God, no. Okay, so I'm going to start with the little disclaimer. That is, this talk is not going to be about just mutations and insertions and deletions and SNPs. This is going to be, I've divided it into different sections. So I'm going to be talking about the changing landscape in precision medicine. How has the work complexity and workload changed for all of us, not only the pathologists? Some case studies. See, all along, we've only been doing assays on, EGFR, KRAS, and BRAF, which has treatment implications. But these case studies will also focus on particular mutations which have helped us make a proper diagnosis. And then how do we achieve our goals together? We are all working towards the same goal, that is patient care. So how do we work together? What are our strategies? And what does Monash have to offer now and in future? So just some warm-up slides. All of us know that precision medicine is emerging, it's rapidly changing, and it's so important. And pathology needs to be part of the precision medicine. And for that, we need robust assays, accurate and timely results, which are very important. And pathology obviously plays a main role in implementation and development of these molecular tests. So we do molecular assays for diagnosis. As we know, every year there's a new WHO book being published on different tumor streams, and each tumor is linked to a particular mutation. So to get the classification right, we need molecular assays. We need assays for therapeutic decision making, and also for patients to get into clinical trials. So this has become standard of care for us, molecular panels, but there is a steep growth in the number of assays which are available, and there are associated financial and cost pressures, as we all know. But the challenge is not only knowing what is the mutation, but it is also important to know what are the practical benefits for the patient. So we are a bunch of doctors who work on evidence-based data. So, it's very important for us to know how the patient is going to get benefited by these tests. So, and what is our role in helping the oncologist guide these treatment-based decisions, and how do we interpret our results? All this is very important for us. So then we were just, with one little microscope and some H&E stained sections. But now we have all these blue books, we have all these equipment, we have all the tests to do. So what we were finishing, each case would probably take us 15 to 20 minutes to finish, even 10 years ago, but now each case takes us 1.5 hours to finish because there's so much more to do. So if you look at the changing landscape with biomarker testing, PDL1 and lung cancers, we were just doing TPS scores, and that was the only biomarker test which we were doing, say, 6 years ago. But there's a big bang now. You have PDL1 testing in head and neck and breast cancers, and we need to give a CPS score. The clones of antibodies used are different, and every platform doesn't work with that clone. So there's a lot more complexity. And then every now and then we have requests for gynae and gastric cancers, PDL1 testing in these tumors, and there are no guidelines for them. And we were working on PDL1 scores in triple negative breast cancers using a different clone of antibody, where we were just coding the inflammatory cells, but that has got dumped now, so it's not relevant anymore. And with the molecular assays, we only had EGFR, KRAS, and BRAF, as I mentioned, but now we have more complexities. We have MET exon 14 in lung cancer, the TERT mutations in low-grade gliomas, BRCA testing in high-grade serous ovarian cancers. So that's one group which has treatment implications. And we have the other group because of our, WHO classification system, where we need to find the mutations and fusions to come to the right diagnosis. And these are some examples. So I'll move on to the case studies. So the first case was referred to us for NGS testing from a laboratory in Queensland, and 17-year-old female presented with a 4-centimeter lesion in the left lobe of the thyroid. Patient underwent a total thyroidectomy with lymph node dissection. So on histology, we saw, the reporting pathologist saw a biphasic tumor with a malignant epithelial proliferation, which showed features of PTC in a background of spindle-shaped cells, which looked like desmoid stroma or desmoid fasciitis. And the lymph node showed metastatic tumor in 2 nodes, and the metastatic tumor deposit were mainly the epithelial components. So these are some pictures. So the one on the left shows the arrow demonstrates the tumor, and we also see some normal thyroid here. And the higher power view shows very good features of PTC. In the same specimen, what was seen was a broad expanse of fibroblastic proliferation, spindle-shaped cells with very low-grade nuclear features, which looked like desmoid fibromatosis like stroma. Now, this was the lymph node. So what we see here is normal lymphoid tissue. This is PTC within the lymph node. And in the same lymph node, we did see some spindle-shaped cells, not as confluent as what we saw on the thyroid specimen. So the immunohistochemical stains were pretty good. The epithelial component stained up with TTF1 and thyroglobulin, the most important markers for thyroid cancer. And the BRAF was also positive. The mesenchymal component stained positive with SMA and beta-catenin, which was quite helpful. So the final diagnosis provided by the referral laboratory was PTC with fibromatosis or desmoid type stroma. This is a very rare variant of PTC in less than 1% of adult PTCs. So the important differential diagnosis in this case is we need to exclude something like a spindle cell anaplastic carcinoma arising in a PTC or a paucicellular variant of anaplastic carcinoma, because there are different treatment implications. So the NGS panel was ordered on the thyroid and the lymph node specimens. So in the thyroid specimen, we were able to pick up the BRAF mutation, which is of strong clinical significance. And the other variant which was picked up was the CTNNB1, which is usually seen in desmoid fibromatosis, in 80 to 90% of desmoid fibromatosis. In the lymph node, we only picked up the BRAF mutation, not the other one. So identifying the CTNNB1 was very important to establish the diagnosis of desmoid fibromatosis. So the desmoid tumors are benign monoclonal fibroblastic neoplasms, which can recur and invade locally. And it's important to distinguish this lesion from benign lesions, which are not monoclonal, and also from low-grade sarcomas. So molecular profiling using NGS is useful for establishment of a treatment strategy in these cases. So if you have a positive BRAF stain, you actually don't need to do the NGS testing, but quite often we see a negative BRAF stain and we have to look for other mutations such as BRAF K601E. And we also sometimes in anaplastic lesions look for NTRK and ALK fusions. At the moment, Monash Pathology has funding for NTRK fusion testing in thyroid cancers. So please feel free to refer cases to us. So in this case, what was the value add of the NGS panels? It had a diagnostic value, therapeutic, and prognostic value. So the second case was a Monash Health patient, a 70-year-old female presented with uterine rupture following hysteroscopic resection of fibroid in a private hospital. So the patient underwent total hysterectomy with bilateral salpingo-oophorectomy. On gross examination, we found a tumor which was 5 centimeters in dimension, quite big. So it was a cellular tumor with tongue-like nodules of plump epithelioid cells. There were no definite tubules. There were some foam cells, which were probably Leydig cells, but there was minimal nuclear pleomorphism, so very low-grade features. So on immunohistochemistry, strong WT1 expression, the ER, PR, and AR are all positive. AR is androgen receptor. There was diffuse CD99 staining, but A1, A3 was quite focal. The CD10 and inhibin stains were largely negative. So based on this, this is the photomicrograph. You can see all these spindle-shaped cells. There's a bit of myxoid areas here. This is the androgen staining, which is strong. A1, A3, which is strong but patchy. CD10 negative. Inhibin patchy. So based on all this, the diagnosis was that of a low-grade endometrial stromal sarcoma, but we thought it was important to exclude sex cord stromal tumor of the uterus. So the immunohistochemistry was really not conclusive of the two entities. Now, previous pathology on the resected so-called fibroid was also labeled as sex cord stromal tumor. So we ordered the NGS fusion panel because of, we wanted to be sure as to what this was. So what we picked up was an ESR NCOA3 fusion transcript, and that is diagnostic of uterine tumor resembling ovarian sex cord tumor. So the pertinent negative in this case was especially the JAS-F1 fusion, which we usually see in low-grade endometrial stromal sarcoma that was absent in this case. So that helped us establish the diagnosis of uterine tumor resembling ovarian sex cord tumor. So the presentation of these two entities is quite similar. The post-operative management is quite different because the uterine sex cord stromal tumor has a benign course. It has limited potential for recurrence. Lymphatic invasion is quite rare. And as I mentioned, they don't have the JAS-F1 and PHF mutations. So in previous studies of 4 cases of utero-SCT, 2 cases showed a similar fusion transcript as we saw in the present case. So in this particular case, the NGS panel had diagnostic, therapeutic, and prognostic value. So the third case is a Monash Health patient, a 27-year-old male presented with an electric shock-like feeling, left-sided weakness, seizures, and collapse. So on radiology, a large left frontal parietal lesion was identified, and a whole list of differential was provided on the radiological report. So the patient underwent a stereotactic craniotomy and resection of the right frontal lesion. Now, on histology, we did see a cellular tumor with small cells in a perivascular pseudo-rosette-like distribution. So we were wondering whether, is this a glioma? Is this an embryonal tumor? The site was not quite right for an embryonal tumor, but then you still have to exclude it. Immunohistochemistry was again a bit confusing because the CD99 was positive, but the GFAP was showed patchy positivity. So it was not positive in the entire tumor. Synaptophysin was negative and the Ki67 index was quite high. So we did issue a preliminary report saying it's a high-grade glioma. We preferred that diagnosis over an embryonal tumor because of the location, site of the tumor rather. And so we ordered the NGS 70 gene panel. Now, as you can see, a very cellular tumor, these are the pseudorosettes. And if you look at this on H&D, you would really wonder about something like a medulloblastoma. CD99, as I mentioned, positive, GFAP, positive in some areas, negative in others. So on the NGS testing, we did pick up the H3F3A mutation, and that is diagnostic of diffuse hemispheric glioma, H3G34 mutant. So two other variants of potential clinical significance, which we identified by TP53, and that is quite often seen in diffuse hemispheric gliomas. So the present case, as I said, resembled an embryonal tumor on routine morphology. The GFAP was a bit funny, was patchy. So by doing the NGS, we could establish the diagnosis. And we also picked up other mutations like TP53. And you quite often see TP53, ATRX, and the PDGFRA mutations in this entity. But we didn't see the others, but we just picked up the TP53 mutation. So these hemispheric gliomas typically affect adolescents and young adults. And this has a glioblastoma-like pattern and can resemble CNS embryonal tumors, as in the present case. The prognosis for this entity, it's quite poor. The median progression-free survival of 9 months and an overall survival of 18 to 22 months. The patients can experience local recurrences, and leptomeningeal dissemination is also quite frequent. So as I mentioned in this case, the NGS panels, the value add was diagnostic and prognostic. I think it's treated the same way as any high-grade glioma, so there were no therapeutic implications. So the fourth case was referred to Monash Pathology for NGS testing. This is an interesting case. A 20-year-old male presented with a right lateral chest wall mass. On histology, it was again a very cellular tumor composed of sheets of monotonous ovoid cells, very prominent mitoses, focal tumor necrosis, and the tumor cells stained quite strongly with NKX 2.2, CD99, Vimentin, FLI1, and the CMYC stains. So the most important ones here are the NKX 2.2 and the FLI1, and I'll explain as to why. All the other markers which are listed here were negative. So this was an extensive immunohistochemical panel done. So again, this is what the H&D section showed, and these are all the immunomarkers. So the preliminary diagnosis was a small round blue cell tumor, and the reporting pathologists in Queensland, they favored the diagnosis of Ewing sarcoma. But on FISH testing, there was no evidence of SS18, EWSR1 or CIC rearrangement. So because of that, an NGS fusion panel was ordered, and an FUS-FLI1 fusion was identified. So the final diagnosis was Ewing sarcoma with a novel fusion. So as we know, it's an undifferentiated small round cell sarcoma of the bone and soft tissue. They usually have a distinct diagnostic signature, and there's usually a fusion of a member of the FET family with a member of the ETS family. And the most common fusions which we see are EWSR1 and FL1, sorry, and that is what we see in 85% of cases. So usually the FISH test is quite useful in Ewing sarcoma and usually gives you the answer. But in certain cases, there are more complex inversions and insertions and structural rearrangements due to which the FISH may be negative. And that in those cases, it's very important to do a fusion panel to come to the correct diagnosis. So in this case, as I mentioned, there was a novel fusion, again, from the same two families, but different, partners, I would say. The CD99 and NKX 2.2 are sensitive markers, and the FLI1 was positive in this case, which correlated with the fusion transcript involving the FLI1. And it is important to do this RNA fusion panel because you want to exclude other tumors such as round cell sarcomas with these fusions or sarcomas with BCOR genetic alterations. So the value add for NGS panels in this case was mainly diagnostic. I don't think there was any therapeutic or prognostic significance. The fifth case, which is the last case in this series, is an 84-year-old male who presented with peritoneal lesions. Again, this case was referred to Monash Pathology for NGS testing. On histology, we saw loose discohesive nests of epithelioid atypical cells with no gland formation or squamous differentiation. There were, abnormal nuclear features. There were some mitotic figures, but not overtly malignant looking. Now, with immunohistochemistry from the referring lab, I don't have the slides of the immunos with me. The CK7 was positive in the tumor cells, and they had the reporting pathologists had done all the other markers to exclude a tumor from lung or prostate or colorectal carcinoma. Everything was negative. So this is the H&D section, and that's all I have. So, pink-looking cells, which is a bit funny for adenocarcinoma, but, and discohesive nests with enlarged nuclei within these cells. So the diagnosis provided was poorly differentiated adenocarcinoma, and they had mentioned in the report that the site of origin of the tumor is not clear. And after extensive CT and all that, CT scans and all the other tests, no primary tumor was identified. The oncologists were quite concerned about the peritoneal lesions only. So they did worry about mesothelioma, and we performed the NGS 70 gene panel. And we were able to identify 2 BAP1 variants as listed here. So the final diagnosis which we provided was peritoneal mesotheliomas. So peritoneal mesothelioma is a very rare malignancy, and it has a poor prognosis. So mesothelioma stains with pan-cytokeratin markers, and that's a common trap because you can mistake it for adenocarcinoma. And unfortunately, we don't have the BAP1 stain at Monash, and the private laboratory which referred the case to us also did not have that stain. And we can see BAP1 truncating mutations in mesotheliomas, head and neck cancers, and in uveal melanomas. And you can also see germline mutations in mesotheliomas, melanomas, and some somatic mutations in renal and endometrial cancers. It's quite, it's not totally specific, but it does help us come to a conclusion. So again, in this case, the value add of the NGS panels was both diagnostic and prognostic. Therapeutic, I'm not the right person to answer. I'm sure there are some differences in the way the 2 entities are treated. So that is all about the cases. Now, I'm going to talk about our challenges and how do we achieve our goals together. So we'll talk about tissue stewardship. What are our issues? Now, tissue is the issue. Now we have less tissue available for testing. More tests are being requested, less resources. Funding is an issue. All of us know about it. Patient management is a multidisciplinary approach. Advances, how things have advanced, it's not that knowledge is not uniform across every, subspecialty in the hospital. The learning curve is different among, and all of us have different layers of knowledge, I would say, and communication amongst peers is also not very ideal. This is not a criticism, this is just my observation, and the more we observe, I think we can improve on what we are doing. So this is where we are. Probably the radiologists are still here, pathologists are slowly climbing up, the oncologists are always on top, so we should all aim to be here together. Now, something about tissue stewardship, there are challenges, and how do we come up with solutions? So if you look at tissue acquisition, the challenges are, say when a radiologist is doing a biopsy, he or she doesn't know what this tissue is being used for. So instead of taking 1 core, if they knew more about the molecular assays, they might take 3 cores. So, so that is, and sometimes, it's very difficult to take cores from certain sites like peritoneal lesions. So if a pathologist or a scientist is happy to do a rapid on-site evaluation and tell the radiologist they are in the lesion, they can take 3 cores instead of 1 core, that will help them. Tissue management is a challenge. Again, there is no standardized approach. Different labs do different things. Different labs section blocks in different ways. For example, at Monash, any tumor, which is, we consider that as very precious samples. We only do one level to start off with, just to make sure there is tumor, and then we order the immunos and molecular testing. Some labs do 3 levels to start off with, so they've already lost a lot of tissue. So, and so to overcome these challenges, sorry, it should have been solution here instead of challenges. We can put co-biopsies. If there are 3 cores, we can put them into different blocks. We keep one block exclusively for molecular testing, and use the others for, immunohistochemistry, etc. FNA samples are excellent for NGS testing, because the DNA quality is good, and we quite often use it at Monash. And if there is a comprehensive genomic panel, I think it provides a lot of answers in one go. Of course, there's an expense involved. And engagement of multiple teams in this tissue journey. I think, as I said, there are issues of knowledge gaps and understanding the assay requirements, etc. So I think the stewardship should be led by a molecular pathologist who has good knowledge on NGS requirements. He or she can educate and guide all the key stakeholders. I think that is the solution going forward. So pathologists, our challenges are, again, I've spoken about the tissue enough. Clinical information is inadequate, is a big issue for us. So we end up doing more immunos to get the right answer, and we are wasting tissue. We are not always aware of the treatment outcome. It'll be good to know and understand the situation a bit better. We have no time to read and keep up with all the advances in oncology, clinical trials, and treatment options. And there's a severe workforce shortage in molecular pathology. This includes pathologists, scientists, curators, and bioinformaticians. So oncologists, I know they have a bigger challenge. They are facing the patients and the families. There's more pressure. They are really dependent on radiologists and pathologists to progress with patient management, and we need to be aware of that and work with them. And then, not all oncologists are across the complexity of the work in the laboratory and what the amount of work which goes into every biopsy. And they frequently ask us these questions: why can't you do more biomarkers? Why is the turnaround time poor? Sometimes when the assays don't work, I mean, it's very difficult to explain as to why it didn't work. So what can we do to bridge the gap for better patient outcome? As I said, I've already spoken about, the cutting the sections, trying to conserve tissue using FNA smears. But I think the most important thing is we have to embed molecular pathology within the anatomical pathology training when they are registrars to overcome these workforce issues. Oncologists, how could they help us provide more information to make us more aware and educate us better about why a test is needed, what are the treatment implications, etc. Also, understand the workflow in pathology a bit better, and involve the radiologists and pathologists in clinical trials right from the time of inception of the trial. Now, what Monash has to offer, what do we have now? What are we looking for in the future? So we had 3 different laboratories, in different parts of the hospital. Now we have a beautiful facility on level 4, E block, and which is all, amalgamated. And we have a new name for the department, which is called Diagnostic Genomics. Now I'll stop talking and I'll show the pictures. The pictures speak for themselves. It's really nice. It's quite spread out and, a beautiful facility which the hospital has provided us with. Different sections of the laboratory, a separate DNA extraction room, a pre-PCR lab, which reduces the risk of contamination. And then this is the instrument equipment we have at the moment: 2 mini-seqs, 1 NextSeq. And then again, I'm not going to read out the tests which we do, but I'll just give everybody a second to read through the whole list. We do constitutional and non-constitutional studies in cytogenetics. This is a thalassemia lab, which does all these tests. And Monash is the reference laboratory for thalassemia. And in molecular pathology, these are the 3 areas of testing. As we all know, the solid tumor, we have these 3 panels at the moment. We test for imprinting disorders, it's more constitutional. And molecular hematology, we have the myeloid NGS panel, which we've recently started, it's up and running. These are the reports we issue. It's quite comprehensive. There's a critical clinical summary which is provided. It also includes in-depth interpretations. we give options of clinical trials, and any other relevant information is always included in the report. So, we are in the process of validating our pan-cancer comprehensive genomic panel. So it should be up and running in the next couple of months. We are working on cardiac panels in hypercholesterolemia, cardiomyopathies. That's in a design stage with the Victorian Heart Hospital. We've managed to get a fellowship through the Melbourne Genomics, and that is for a bioinformatician to work on whole exome sequencing. With Mark's help, we've managed to get the MPCCC fellowship for pathologists who can obtain the certification through RCPA and also participate in molecular tumor boards. We've had 4 publications till date in this year, and 2 more are in the pipeline. And then we also plan to have some on-site training for anatomical pathology and oncology registrars, but that's in the development stage at the moment. Thanks for your attention, and I'm happy to take questions.
Great, thanks so much, Beena. Very comprehensive overview. And we've got some time for questions, which is fantastic. So please, if everyone could just, I don't know, like raise their hands or something to ask questions, or pop them in the chat, and I'll try and track that. Can I might just take Chair's prerogative and kick it off, Beena. So how much more expensive is it to do, just a whole exome plus, say, RNA-seq analysis on every sample, rather than having a very large number, and it seems like an exponentially increasing number of different focused panels, DNA panels, RNA fusion panels? The landscape of tests that's available is really complex. So as a clinician, okay, ordering the test like at the coalface with the patient, it's virtually impossible to accommodate that complexity as it exists, let alone the dynamic changes that are always occurring. Why can't we just, or how far away might we be, because it feels like this kind of has to be the future eventually, from just doing whole exome and RNA-seq on every patient, or at least every patient where molecular profiling is thought to be indicated?
Good question, Mark. I wish I had the resources, but I think, see, there are a couple of things. Smaller panels, the turnaround time is going to be much quicker. Say, if that mutation is going to guide treatment, then, you would rather go with the smaller panels. And obviously, it's less expensive. There's less bioinformatics involved, less curation involved. But the larger your panel becomes, you need a bigger piece of equipment, and obviously more expensive. But at the same time, I think the amount of data you generate, the amount of curation which you have to go through, and the bioinformatics support you need, that's massive. I think that's where the problem will arise. Leave alone the expenses. See, a panel might cost you $400 to $500. The whole genome, whole exome will probably cost you $3,000. But then, I think that it will affect the turnaround time, and also, the amount of data and the bioinformatics support which will go with it.
Thanks. Padma, I've got your hand up as coming first. Just introduce yourself and go ahead.
Yes, sure. Hi, Beena. That's great. I'm Padma Murthy. I'm a placental biologist working in pharmacology department at Monash BDI. I'm interested in more on the choriocarcinoma. Do we get carcinoma screening or pathology coming to your lab at Monash Health? Because it seems more prevalent in Asia, but I was just wondering, are there any cases that come across to Monash Pathology, choriocarcinoma cases in Melbourne, or across, if you know any, in Australia?
I don't, thanks, Padma. I don't think it's that common. There's no screening program for choriocarcinomas in Australia. And there's no funded screening program like breast screen or, cervical cancer screening and all that. But, we do see choriocarcinomas, but it is not, we're not seeing it every day. It's not like, a barn door breast cancer or, PTC in the thyroid or whatever. It's not that frequent, but we do see. And, we have archival tissue from, 20, we have to store it for a long time. So if you go to our database and search for this, we will certainly be able to find some, it won't be fresh tissue, it'll be formalin fixed paraffin embedded material.
So it is archived. Can researchers have access to it if we put in ethics and with ethics approval? Do we think that we will be able to access it for research purposes?
Yeah, I think you need ethics approval and also a consent waiver, because if these are cases from the past, then you need to have some kind of a patient consent to use the tissue, or you need to have a consent waiver. You need both.
Thanks, Padma. So I suggest you take that offline and understand from Beena via email or something what's actually required to get access to those samples. There are some regulatory and ethical complexities around that approach to getting samples that she's alluded to. Although there are ways around that sometimes. Next hand up I've got is Vicky. Great to see you, Vicky. Vicky was of course the founder of our precision cancer program. So it's great to see you dialing in, Vicky. You probably should introduce yourself just so we're reminded of who you are and go ahead and ask your question. Thanks, Vicky.
Oh, yes. So, hi, Mark. Thanks, Mark. I used to be the program manager for the MPCCC Precision Oncology program and set up MTBs and was involved in setting up the, tumour profiling aspect of things along with pathology, sometimes, or at least, consulted about that. I'm on a break now. But I'm still obviously very interested in keeping up with everything. Beena, thanks for the rundown. It was really, really good, really helpful. I've got 3 questions, but they're all pretty short. The first one is you mentioned about taking cores and making 3 blocks from them, and one of them is used for molecular pathology. Is that's correct?
Yeah, that's right. Yeah.
So are they all FFP blocks, or are they, because it just seems that if you take a block, take tissue, put it in FFP, it'll sort of screw up the DNA for a little bit for next gen sequencing. So it's kind of like would be a backward step if that's what you do, or is it a non-FFP block? Is it formal?
No. What happens, Vicky? The issue is, if you have only one block with say 3 cores or 2 cores, you're trimming through the block to do the immunos.
Yes.
So if you're conserving one core exclusively for molecular testing, then you are not compromising on the amount of DNA which is available after immunostains.
Yeah.
So FFP tissue is actually very good for DNA and RNA. All the fusion panels which we've run, they are all on FFP tissue, paraffin embedded material. So we've not had any issues, except when the pathologist has done so many immunos, you've trimmed through the block, there's very little tumor left. But even that, before we get on to the NGS, we assess the amount of tumor in the specimen, by looking at the H&D slides. Yes,
I understand that, but I was wondering whether you have a separate block which is only used for molecular pathology, or you're saying that they're all used for anatomical pathology potentially, and one is just in case used for molecular pathology. So it's just that if there is one that's particularly dedicated for molecular pathology, and although DNA and RNA sequencing work from FFP blocks, they obviously work a lot better from fresh frozen tissue. So I was wondering if there could be, one dedicated that is stored fresh frozen for molecular pathology, which would improve the quality of the sequence and require less DNA used basically. And have higher quality,
Absolutely, that's a good point. Fresh tissue is always better, but we have other issues like where do we store, and you have to have proper data management behind all that.
Sure.
So, and then I think all our tests, our NATA accreditation is only on the FFP tissue. So we haven't been accredited for fresh tissue.
Okay.
So
got you.
that's the difference.
Got you. Yeah, thanks. And the other question was around, you mentioned cytology smears, and there's that supernatant method that I think Vivek and others were looking at. I was wondering, so basically, as you know, the supernatant would normally be thrown away during the preparation of the sample, but whether you're going to look at using the supernatant for next-gen sequencing purposes.
So at the moment, we are helping two clinician researchers with the supernatant. One is Dan Crow, who
Yes,
works on
yes.
pancreatic cancers,
Yep.
and Michael Mond, who does work on thyroid cancers. So we are
Okay.
helping both these groups with the supernatant.
Great. Okay, sounds good. Just one quick question. Your more comprehensive panel that you were talking about, how many genes is that? And is it a TSO 500 or something else?
It's not TSO 500. It is close to 400 genes, but I can't go into more details because we're still in that contract stage. You know, it
Okay.
hasn't been signed yet. So yeah.
Okay, no worries. Thanks, Beena.
Kevin, I've got you as my next hand up. Just introduce yourself and fire away.
Hi, Mark. Thanks, Professor Beena, for the very comprehensive talk. I've learned quite a lot today. So, I'm a sales manager with SomaLogic. We provide proteomics and services. So, I'm just curious, coming from a proteomics point of view. I don't have any clinical background. I don't have any pathology background. So, I'm just curious, like, why, even though immunohistochemistry has been quite a old technology, it's been still quite widely used and accepted in a lot of the pathology analysis for the clinicians. There's a lot more newer technology out there that we could sort of use less samples. We can look at more markers. There's higher throughput, and then they are a lot more costly. From my understanding, a lot of those immunohistochemistry tests, they're about, with the Medicare benefits, they're about $500 each. Some of the more newer proteomics tests, they are actually more sort of cheaper in the sense like you get more samples through and you get more analytes. Could you comment on that?
Yeah, from an anatomical pathology perspective, I think we are very morphology based. So we would also like to look at which cell is showing a positivity, just because something is brown doesn't mean it's positive. So, is it nuclear? Is it cytoplasmic? See, for example, beta-catenin, in one of the cases I showed today, if the beta-catenin is a cytoplasmic stain, it's as good as negative. But if it is the nuclear stain, it has value. So I think as pathologists, we would like to see where the protein is being expressed. Is it in the cytoplasm? What is the pattern of staining? Is it membranous? So that's the advantage of immunohistochemistry. And obviously, the turnaround time is very important for us. So if I order an immuno this morning, I'll get it by this afternoon or latest by tomorrow morning. So I'm able to provide an answer quickly. For example, in breast cancers, you diagnose breast cancer, then the surgeon and the oncologist want to know whether it is estrogen receptor positive or HER2 positive, whatever. So, that answer I'm able to provide the following day. But if I'm going to depend on proteomics and all that, that's going to, we don't have the resources now. We can't do it at the moment. Yeah, it might be the future, but then I think it can be an adjunct, but it cannot be a substitute for what we are doing. That's my opinion.
Beena, what about, just to extend the question, it's a great question actually. What about, there's a lot of very kind of standard, if you like, they're not even really technological advances anymore. It's pretty standard things such as, multiplexed immunohistochemistry, or it's usually immunofluorescence, where you can, look at, relatively large numbers of different proteins in the one section in the one test. So we do this in research reasonably routinely these days. And it strikes me that, because I know you guys have a lot of very standard antibody panels that you apply, depending on the kind of pre-test probability, the sort of likelihood that you think it's one of these diagnoses. But you could certainly imagine a future where you narrow down the list of potential differentials and then you just apply it to a single section, your standard sort of antibody interrogation panel, in a way that might save a dozen sections, or sometimes more for these difficult cases that take a long time. I mean, I can immediately think of several clinical cases that we've had that have been, where basically the patient's management has been compromised, not through poor practice, but just because there was a requirement to take so many sections to try and figure out what type of cancer, that we had nothing left over for molecular at the end of it. If you had a panel that just took one section and then did all the antibody tests that you needed to do to narrow down the diagnosis from in terms of standard and path processes, then you'd have all this tissue left over for molecular. Why is that not possible or not done in a diagnostic sense? Or are there moves towards that?
At Monash, we are sort of moving towards that. So we have a lot of duplex antibodies. So we can only combine antibodies which stain different parts of the cell. For example, we have combinations of nucleus stain and cytoplasmic stain. A good example is, say, in breast cancer, you want to make sure it is an invasive versus in situ tumor. So we try to combine LMCK, which has which is an epithelial marker. It looks pink under the microscope, and we have the P63, which is a myoepithelial marker. So those groups of cells which don't have the brown stain, they are all invasive, and those which have brown and pink, they are in situ carcinoma. So we are moving towards the duplex stains. It saves time, it saves on resources, and also you get a quick answer, and it's a more accurate answer. It'll be very useful, Mark, for things like brain cancers, where the amount of tissue you have is very little, and you can't keep going back and forth. So if you can combine some of the lymphoma markers, for example, it'll be brilliant. But the thing is, the challenge will be, where is the protein being expressed? Is it in the cytoplasm or in the nucleus? So you can only combine so many antibodies. But I have seen presentations where they have combined 6 or 7 antibodies in one on one slide. So that's probably the future.
Thanks. Next hand I've got is Peter Fullers. Thanks, Peter.
Thanks, Mark, and thanks, Beena. It's amazing how far things have come in such a short time at the service level. Congratulations. I just had a sort of trivial question, actually. It was obviously case one. You talked about a mutation in CTN in B1 in a very atypical case, and it made me ponder about whether that was germline or not, and whether in these analyses, how you dealt with the possibility of germline. Do you routinely run germline DNA across the panels, or is it all simply set up on the presumption of somatic mutations and just tumour DNA?
At the moment, we're just doing tumor DNA, Peter, but it's a good thought. And we have actually discussed this case several times, whether we should be using normal tissue and tumor tissue from the same patient and see if there's any difference. And, we are not doing any germline testing at the moment. But that's a good thought, yeah.
Any questions, just pop your hands up. So Beena, I wanted to actually get you also to expand on the issue, which I personally think is actually the biggest issue linked to this field, and that's the workforce development issue. It's, really clear that there just aren't enough molecularly trained pathologists, full stop. And so I guess we've been particularly excited in the current funding round of MPCCC to quarantine some budget to support development of molecular pathology training capability, essentially, within your service, and also the public pathology department at the Alfred. What is being done? So, what more can MPCCC do? What more can the state government do? And what more can be done nationally and even through the college to, and what also is being done to address this? Because it's almost, I would argue it's almost the main, like the technology is just flying and it's actually miles ahead. I would argue that the biggest impediment to being able to roll out the technology through all the means that you've suggested to make it as accessible as possible to as many patients as possible. I'd actually argue the main rate limiting step at the moment is the dearth of adequately trained molecular pathologists. So what's the status quo of addressing that issue, and what else can be done, and how can MPCCC and this wider network help towards that?
Yeah, I'll take a step back, Mark, and I think pathologists is, the medical workforce, but I think the scientific workforce, curators and bioinformaticians, we also have to focus on that cohort, because, there are very few well-trained scientists who can run all these assays. And the most important thing is they need to know how to troubleshoot. It's all good to have, all these ready-made assays and platforms and all that. But if something goes wrong, you need really a skilled scientist to troubleshoot. So I think we need to really build the scientific workforce. And at Monash, what we've curators is the other, limiting step, because there are not that many curators. And so what we need to do is, so at Monash, what we are doing is we are trying to overcome that by asking the pathologists to do some curation. So there are scientists, so there are curators who are specifically trained to be curators, but some of the scientists who run these assays are also curating now, which is, they are broadening their skill set. And the pathologists are also doing a lot more curation. And the analogy we draw is, when we cut a specimen and we report as anatomical pathologists. So similarly, if you don't curate, if you don't cut a specimen properly, you don't know what you're looking at under the microscope. So similarly, if you don't curate, you won't know what you're looking at, as the end product. So these are some steps which we've taken at Monash. But I think it has to be a bigger push from the college level. They have to integrate this molecular training into the AP training and make it compulsory. At the moment, it is just, we ask one question during the exam and, there's one slot during the Viva. That won't do. It should be integrated, and they should be examined. Only then they get serious about it. And I think we should encourage more pathologists to, get the module certification from through the college. It's an exam process. And at the moment, we have 3 pathologists working in this space at Monash. So we just have to keep encouraging, the younger generation to take up this as a subspecialty. And of course, your support is very, I really appreciate that, because that will give us some more, what do I say? It gives us more opportunities to, strengthen the workforce.
Great answer. So Kevin, is that a legacy hand, or did you have another question?
Oh, yes. Thanks, Mark. I've got a second question, but I've got a comment to add to what you've just said about the workforce issues. I think from industry as suppliers, we also have a part to play. We need to support the pathologist, the clinician, and by providing sort of, we can't just dump the whole data set to the clinicians. We need to find a better way that we can better present some of those data, so that when the clinicians do, or the pathologists do look at those information, they don't have to take too long to decipher the message. If we could find like a sweet spot whereby somehow, hopefully in the future, with AI and things, we could better improve our understanding of diseases, and we could, from a supplier point of view, if we could better deliver information in a more concise manner that's easier for clinicians to interpret, I think that would greatly help. That's just my point of view with regards to what you've said. But my question to Beena is, going forward, we would see that liquid biopsy is quite a common sample type to be used. Like, do you foresee other sort of, rather than taking tumor samples, going forward, a lot of those sample types will be liquid biopsies in terms for diagnosis?
Yeah, I think that's an emerging field. It's a growing field, and I think it's more practical, because as I said, certain biopsies are not easy to obtain, lung cancers and, peritoneal lesions and, retroperitoneal nodes. So you can't keep, especially in lung, I think you might end up giving the patient a pneumothorax. So it's better you don't biopsy it every 6 months. So I think liquid biopsy has a major role. So, but we are not there yet. We are thinking of it, but we have to get our pan-cancer panel working first, and then we'll think of liquid biopsies later. Again, there's no funding, Kevin. That's the other issue. We can't keep developing more assays, and where do we get the money from? So that's the other question.
All right. Thanks, Beena. Thank you.
Yeah, it's a good comment. There is certainly, this is the sort of area that's really ripe for government investments in, sort of seed and pilot projects to work out how these technological advances can be adapted to diagnostic settings, particularly public hospital diagnostic settings. So we should talk about that more, Beena, because I can think of a few ideas in there, potentially linked through MPCCC, where we could try and procure such funds for that development. Okay. Thanks so much, everyone, for dialing in, and thanks very much, Beena, for a very interesting and informative seminar. It's great to hear a summary, I suppose, of this. Obviously, there's those, really interesting and in many cases quite remarkable cases, and it's obvious that this is, the the cutting edge of standard practice, not rather than the future, and when the issue is really how do we take it into the future from here, and that's what certainly a major part of MPCCC's focus going forward is ongoing focus on an investment in that space. So thank you so much for your contribution, Beena, and there's a few interesting things to follow up there, which we can talk about in due course. So it just remains me to thank everyone again for coming and to remind you of the next seminar, which is scheduled for June the 6th, which is like next week, I think, with Dr. Tu Nguyen Dumont, who'll be presenting on genetic testing for breast cancer susceptibility. Is it time for population testing? Please visit the MPCCC website for more information on how to attend this event, Zoom logins, etc., etc. Everyone have a great day. Thanks again for attending, and see you next time. Bye-bye.
Thank you. Bye.